Good morning. We are quorum now, so we're going to start with the meeting. I would like to begin by welcoming everyone to this meeting of the joint Cambridgeshire and Peterborough Health and Wellbeing Board and Integrated Care Partnership at Newshire Hall. Filming and photography are welcome at this meeting, but please, can everyone present turn their phones to silent or vibrate while the meeting is taking place? The meeting will be live streamed and a recording will be available to view later on the County Council's website. There is no fire alarm test scheduled for today, so if the alarm sounds, I will adjourn the meeting and we will leave by the center doors to my left. There is a fire escape next to the kitchen and we will assemble at the far end of the car park. If the meeting runs beyond 2 hours, we will take a short break. And I would like to begin paying tribute to two former members, John O'Brien and Councillor Dr. Shabina Kayum, who both serve as co-chairs of this group. John was instrumental in developing this committee in common with the Health and Wellbeing Board and Integrated Care Partnership, and has been a pivotal figure in developing its work. He stepped down as a chair of Cambridgeshire and Peterborough Integrated Care Board in September. I personally would like to thank him because he showed tremendous interest and he devoted a couple of hours of his time in this place just to talk to me and to share his knowledge. And that shows the generosity of kind that he was. Shabina Kayum has also been an active and engaged co-chair, and now she is leading the Peterborough City Council. Shabina is succeeded by Councillor Samir Ali, Peterborough City Council's new cabinet member for communities, poverty and public health, who joins us for the first time today as our new co-chair. On behalf of everyone present, I offer him a warm welcome. Would Democratic Services Officer report any apologies for absence, please?
Thank you, Chair. Apologies have been received from Dr. Jag Aluwalia from Royal Papworth, Professor Steve Barnett from NWAFT, Rob Bridge from the Combined Authority, Councillor Katie Cole from Peterborough City Council, Jonathan Jelly from Health Watch, Louis Camphor from the Integrated Care Board, Paul Med, who's the District Council Rep North, Darryl Preston, the Police and Crime Commissioner, and Piers Ricketts, the Eastern Academic Health Science Representative. Jan Thomas also sent apologies that she'll be joining slightly late today.
Members, we will begin by going around the room to establish who is here and what organizations we are representing. I will start with myself, Councillor Luis Navarro. I am the Vice Chair of Cambridgeshire County Council's Adults and Health Committee and Co-Chair of the Health and Wellbeing Board. Why don't we start with you, Ali, please?
Councillor Zamir Ali, Cabinet Member of... oh, my apologies. Is that? Exactly. Councillor Zamir Ali, Cabinet Member for Communities, Poverty and Public Health at Peterborough City Council.
We go around this way, Patrick, with you, if that's all right.
Good morning, everybody. Patrick Warren Higgs. I'm the Executive Director for Adults Health and Commissioning at Cambridgeshire County Council.
Hello, everyone. I'm Liz Watts, Chief Executive of South Cambridgeshire District Council.
Hi, I'm Kate Vorton. I'm the Executive Director for Partnerships and Neighbourhoods and Place from the Integrated Care Board.
Good morning. I'm Dr. Mike Napton. I'm a Non-Executive Director at Cambridge and Peterborough Foundation Trust.
Good morning. I'm Neil Moder. I'm a GP and I'm here to represent the North Place Partnership.
Good morning. Sally Cartwright, Director of Public Health, Cambridgeshire.
Good morning. Raj Lakshman, Director of Public Health, Peterborough.
Good morning. I'm Graham Wilson. I'm Chair of Cambridgeshire, so to here, Health and Adults Committee.
Good morning. I'm Paul Rogerson. I'm the Head of Prevention and Partnerships for the Constabulary.
Good morning. I'm Melanie Pittock. I'm here to represent the voluntary sector and I'm also Chief Exec at Age UK, Cambridgeshire and Peterborough.
Thank you very much. Does any member wish to declare any disclosable pecuniary interest or non-statutory disclosable interest? We are being asked to approve the minutes of the Cambridgeshire and Peterborough Health and Wellbeing Board and Integrated Care Partnership meeting on the 13th of June 2025. If any board member wants to raise any questions on the accuracy of the minutes only, can they do so now? I see no objections, so we will take that as carried unanimously. On the basis of the recommendation, we approve the minutes, carried, that's done. So we move to item 3. Is the future role of the Integrated Care Partnership in light of national reforms? Kate Botton, the Chief Officer, Partnerships and Integration, will introduce the report. Kate, please.
Thank you. I'm going to take the paper as largely read, but just to go through the key points. We received a letter as part of the wider NHS reforms that are underway at the moment and widely publicised that the Integrated Care Partnership Board and our Health and Wellbeing Board is a joint board with the Integrated Care Partnership Board as well. The Integrated Partnership Board element nationally has been notified that will be stood down. And the paper outlines, building on the work that we've all done together in the last year, the desire to, given the level of change at the moment where we have a move of our Integrated Care Board into a broader cluster, which covers Hertfordshire, Beds, Luton and Milton Keynes, as well as Cambridge and Peterborough, which is underway currently. And Jan might say a bit more about that later when she arrives. But also the wider context of local government reform, etc. In discussion with the chairs and more broadly, the proposal is that we remain as a joint committee from the Health and Wellbeing Board and Integrated Care Partnership during this period of transition, so we don't lose any momentum and any support and build on the work we've already started. Looking at how we support our neighbourhoods, how we support our places, how we start to work together in a more integrated way to deliver for our population. At the moment, the proposal is to keep the arrangements as they are during the transition period, to make sure that we can remain safe, but also grab the opportunities that we've already started to identify and build on the work that we've already started to do together. It's one of the few occasions where we come together with our elected members as well. And from a health perspective, that's very important, and how we use your voices to empower right down to our neighbourhoods and understand actually how do we work with all of our collective levers to achieve what we want to try and achieve for our population. So the ask of the board, which is in section 2, is to remain as we are and as we have been meeting for the last few years during this period of transition, which we'll revisit at a later date. But just to note that there is a national policy change around integrated care partnerships. We would maintain the local arrangements, but also just making sure that you're cited on the rationale for this, just because of the level of change that exists at the moment in the system. Happy to take questions.
Any questions for Kate, members? Or any comments? Sally?
Thank you. I'm supportive of the proposal to not undo the great work that's been happening, having this wider partnership and footprint, and the relationships and building on the LGA work that we did earlier in the year as well. I think it would be foolish to sort of unpick it at this point. But I do think it would be good to think through and perhaps formalise a bit more as the guidance comes out rapidly and the position unfolds around neighbourhoods and what that means, what the role of this board then is. And we had a brief conversation about this earlier in the week, Kate, around the governance of the new neighbourhood committee and how that will all work and how we make sure that we're functioning as a system for the neighbourhood work and neighbourhood committee, and then up to place and up to the new ICB. What actually is the role of Health and Wellbeing Board supposed to be within that? Because there is in the 10-year plan wording around neighbourhood plans having some oversight at Health and Wellbeing Boards. But but that's not particularly clear around what that actually means. But it would be helpful as part of this conversation to really try and firm that up for us all, so that we can build on the conversation that we had at the LGA development session around giving legs more to place and how that works. But actually really try to work that through as part of all of the governance discussions that are ongoing.
Yes, Mike.
Yeah, myself. Yeah, sorry. So I think building on Sally's point, that I think I'm very supportive of the paper. I think it's absolutely the right thing to do is to keep building and build on what we've got. And I guess I'll just echo the point about making sure that we're using place in the best way possible, because actually a lot of the Health and Wellbeing Board agenda and ICP agenda, the future hopefully will be that place is a key delivery partner of that. And so really thinking about, when there are areas which could be, to do with a lot of the papers today, frailty, better care fund, older people, etc. I guess the new way of working is to kind of delegate the strategic ambitions down to place, and then place to enthuse its neighbourhoods to really deliver on those agendas. And obviously, we were delighted that as part of the North Care Partnership bid, that was approved to be one of the national pilots. And I think there's a real opportunity then. We're one of the 43 areas in the whole country that's really going to kind of focus on data, focus on outcomes for the population around Peterborough and Fenland, and really we're going to try and drive through changes. So, I think the challenge for us in that is that there's no specific funding that's been put aside for this program, which then makes it challenging. But I think, the national leaders will say to us, well, you've got a lot of funding in Cambridge and Peterborough. It's how you use that funding. So when we're talking about Better Care Fund, when we're talking about Section 75 agreements, when we're talking about programs to help frailty, I guess it's kind of like, how do we keep the status quo while still then moving in the direction that Kate has articulated, and Sally, that actually we move towards place being a key deliverer for change for our communities.
Thank you, Neil. Anyone else? Patrick, please.
Yeah, thanks, Chair. Excuse me. It's really to progress on from the previous 2 points. So I think we should also be mindful of other changes, not just around the ICP, but other changes that will come out. So the changes particularly to Health Watch, and then the roles that councils will play as the LGR starts to take effect, and the implications that has for place-based partnerships. Certainly we should be focused on looking forward whilst we're supporting and continuation of the strong partnership that we have already through this arrangement, but certainly thinking forward of the other implications of other changes and how we build those in to maintain that strength of partnership.
Thank you, Patrick.
Yes, thank you.
Yes,
I agree with you that this is really important, and additionally so because working in a provider organisation, the financial conversations that are being had at the moment are very austere, and to have a forum like this, which enables us to have a place where health and well-being is discussed, is critical, I think, more so than ever. And it enables boards in provider organisations to at least make those financial decisions in full cognizance of the quality and equity impacts of the decisions that they're making, some of which will be difficult. And I perhaps refer to the disinvestment in Arthur Rank hospice beds. That is understandable, I think, but the consequences for community care, equity and such like are significant. And this is one of the places where those discussions can be had. So I think it's very good to hear that there's stability during this period of not only reorganisation, but financial turbulence as well. So that's the right word.
Thank you, Mike. Any other comments or questions? Yeah, I think it's Kate.
I suppose just to finish off, maybe bring it together slightly. I think there is something about, and we've talked about this a lot previously, but we've got an opportunity now to make sure, A, we continue to build, but also we can really collectively articulate how we are using forums like this, forums like as we move to a cluster and the ICB board starts to meet in common, as part of that, we will have a neighbourhood and partnership committee that covers Cambridge and Peterborough, what that looks like, how that governance model works, and nailing that down has to be done in conjunction with the partners around the room. That's part of the conversation Sally's referring to, which I was in earlier in the week. I think we've got an opportunity to do something because all of us have collective responsibilities for the development of our neighbourhood, and we'll be held to account for that. But also from a people perspective, there's a lot that we can be doing together, to Mike's point around looking at what the resources is and how those decisions are being made. Having areas and spaces like this where we can escalate and use some of our collective authority and levers is going to be really key. But I think it's an accountability for all officers in the room rather than it sort of sitting in one pocket.
Absolutely. Thank you, Kate. Yes, there is an opportunity, and I hope we are really influential in the opportunity that we're being given. So we will move to the report recommendations, unless anybody else has any further comments. You may, yes, of course, Amir.
From my perspective, LGR is around the corner, and we don't know what the split is going to be like. So when that comes out, there will be a lot more conversations. I mean, this is wonderful how everyone's coming together, but do take that into consideration going forward as well, because we don't know what kind of splits there will be within the county itself between Peterborough, Fenland, and there's multiple different, how should I put it, sections that could be integrated to each other. So just to take that into consideration when going forward.
Yes, Neil.
So just as a point of clarification, I think there was an interesting question about the governance. So is health and wellbeing boards to place or place up to health and wellbeing boards? But I think there are some official kind of recommendations that health and wellbeing boards should sign off the neighbourhood plans. And so actually, back to governance wise, we can't, as part, I think it is fundamental that we meet here and talk about things, because I think then the health and wellbeing boards does have that kind of role and responsibility to make sure that the neighbourhood plans are delivering what the health and wellbeing board wants to see going forward. So,
Thank you very much, Neil. Yeah, definitely an influential position that we should exercise with confidence. The Health and Wellbeing Board, unless anybody else has any comments, is being asked to endorse the proposals set out in section 2 of the report, or not any further review of the integrated care partnerships arrangements. Note that a further review of the integrated care partnership arrangements will be brought forward once there is clarity on the future local authority landscape and the outcome of the integrated care board clustering work. I will take in that, unless there are any comments. No, sorry.
It was just to give us an outline of what those triggers might be, just so we're clear what clarity we're seeking to what level, because often we are continue to operate in less than clear working arrangements. Looking at the pace of change that we've seen over the last 6 months, we can anticipate it will continue to do that. So it might be useful for the board to draw some lines in the sand as to what clarity we're looking for and when we'll make that decision formally.
Kate?
Do you mean clarity in terms of how you kind of evolve and make the decision on whether we continue with the integrated care partnership and health and wellbeing board in its current form? Is that what you mean?
Yeah, yes, I think we can agree that it's sensible to hold our position until we have clarity. It's just I think it's worth highlighting, and for a matter of record as well, exactly the clarity that we're waiting for. So either a timeline or a publication of guidance. We've talked about LGA as well, which again the timeline's becoming clearer, but it's not completely clear. But just in terms of public transparency, what we're waiting for.
Yes, Kate.
Yeah, so I think what we could probably do, and I think a big ask or a big priority needs to be how we translate what's happening at the moment really clearly, so people have got line of sight in terms of what the journey will look like. We are looking to merge the ICBs by April 26, and the governance will evolve over that period of time as well. So I think we've probably got a more defined timetable, and then obviously LGR is playing through as well. And maybe also coupled with that, we've made commitments on our side, definitely, about understanding and mirroring some of the decisions that are made as part of LGR, so that actually the priority remains the neighbourhood, and it remains how you kind of support our place geographies, but also being very cognizant of those changes that are going on around that. So it might be we could put the two timelines together, maybe with some of the other underlying principles. I can get the team to have a look at that.
Thank you, Kate.
Okay.
We will move to the report recommendations. Everybody in agreement? Yeah. I would take that the board is happy to support this recommendation unanimously, unless anyone indicates otherwise. Approved. I'll take we move on. Item 4 is the Cambridgeshire and Peterborough Suicide Prevention Strategy for 2025 and 2029. The report will be introduced by Kathy Hartley, consultant in public health at Peterborough City Council, and Richard Merrick, a public health specialty trainee at Cambridgeshire County Council. Well,
hello everyone, can you hear me? Thank you. So yeah, we're here to present the third refresh of the Cambridgeshire and Peterborough Suicide Prevention Strategy. So the very first strategy was over 10 years ago now. So very much this strategy is building on those foundations we've put in place for over the last 10 years. And it's a chance to reflect and focus on an opportunity to reflect and focus and grow the momentum for this agenda, this very important agenda. So we wanted to look back on the progress that we've made as a system. And so one thing that is particularly strong about suicide prevention across Cambridgeshire and Peterborough is our system partnership. We've really grown those partners that join together on a regular basis to support the suicide prevention agenda. And that's a momentum that we've seen grow and grow and grow across our partnership. Another thing that has really made a lot of progress is we were one of the first areas to implement a real-time suicide surveillance program. So this takes suicide data as it happens, and we reflect and learn on those incidents as they happen. So we were literally one of the first places in the country to do that. And we are one of the first places to set up a bereavement support service as a result of that real-time suicide surveillance. That's one of our sort of successes, and we're building upon that and learning as we review the suicides as they come, the suspected suicides. And what we have done prior to this development of the refresh is we have gathered a lot of data and done an in-depth needs assessment for suicide and self-harm across Cambridgeshire and Peterborough. So I just wanted to give you a little bit of reflection on some of the work that has been done. And I'm just going to give some feedback from the Stop Suicide work that is hosted by CPSL Mind. So this is reflection after attending one of the workshops. So attending the Stop Suicide workshop was a powerful and eye-opening experience. It made me reflect deeply on how I listen to people, not just to their words, but to their tone, their silences, and the subtle signs that someone might be struggling. Working in rural Finland, I see firsthand how isolation, poor transport, limited job opportunities, and a lack of basic services can weigh heavily on people's mental health. The workshop helped me understand the importance of asking direct but gentle questions, and more importantly, how to truly listen. We can't fix everything, but sometimes, just by being present, showing we care and taking action can make a world of difference. Thanks to the Stop Suicide workshop, I now feel more confident in recognizing when someone is reaching out, and I've learned how to respond with compassion and clarity. Now I'm going to just hand over to Richard.
Thank you. So we also wanted to share some quotes from individuals who've been supported by the local suicide bereavement service, which is provided by Lifecraft, a local charity. And this often involves support over an extensive period of time, up to or beyond a year, and includes one-to-one support, group sessions, and counselling. At a time when I was so low, you were there to help and support. I will never get over it, but I have learned to live with it, with some support from the service. I'm incredibly grateful to have been able to use Lifecraft's services. They were there during one of the most traumatic times of my life and were my emotional safe place. The service I received was amazing and helped me massively over the last year. The group sessions and one-to-one sessions were very helpful with coming to terms with what happened in my life, and I can't thank you enough for the support over the last year. Lifecraft services gave me the support to work through the various stages of distress and stress that I went through following my son's suicide. Because they uniquely deal with suicide, it felt very safe and non-judgmental. So I just wanted to briefly describe how we've gone about refreshing the strategy to look forward for the next 4 years, as set out in the paper. This has taken as its inputs the previous strategy and its achievements, but also the recommendations that came out of its evaluation. The national strategy, which was launched 2 years ago. The needs assessment chapter, which Kathy described, which was a big system piece of work, drawing data from different parts of our system and taking on board national evidence as well. It also includes the National Confidential Inquiry into Suicide and Self-Harm report, which is focused on mental health services, and recent NHS England guidance about safety planning and moving away from risk stratification. And it's also involved extensive stakeholder engagement with the partnership that has already been described with the organisations represented in this room today, and a process of iterative prioritisation over recent months. So I'd just like to highlight the 5 priority areas for action, which we're looking for you to endorse today. The first is to equip professionals and the public with the skills and awareness to prevent suicide. The second is to focus as a system on improving the treatment and support for people with affective disorders to prevent suicides. The third is to promote awareness and action within our system to prevent suicide in other priority risk groups. The fourth is to use data to drive preventive action and support following suicide attempts and suspected suicides. And the fifth is to improve the capacity and coverage of suicide bereavement support services to support more people bereaved by suicide. So I'll just highlight a couple of areas within these. First is the second area described, where we really want to use this strategy to bring about focus as a system, as recommended also in the mental health JSNA, to make sure that we are providing evidence-based treatments for affective disorders to the best of our ability in a joined-up way, and also to think about those wider psychosocial needs of individuals with affective disorders. We've heard about the progress we've made with real-time suicide surveillance, and the key ambition here in this strategy is that we'd like to go further and move upstream to be able to monitor suicide attempts and to bolster the support available in our system after suicide attempts, to really focus on preventing completed suicides. And lastly, just coming back to those testimonials we heard from people who've benefited from our bereavement service, just to highlight the ambition here to really ensure that this service is run on secure financial footing going forwards, and that we make sure we cover gaps that exist locally, but also maximize the impact this service can have. And just a note on next steps, we have a new suicide prevention manager for the system who will be in post and starting within the next month, who will be leading the implementation of this strategy. And through that, developing more detailed action plans with partners through the Suicide Prevention Steering Group. And furthermore, to establish the monitoring and reporting and evaluation of this strategy.
I just saw the end on there are some challenges with this strategy. So we are reliant on the commitments and collaboration of our system partners represented on the Health and Wellbeing Board. So we just need to encourage and make sure that we have the support for that partnership. The long-term funding for suicide prevention is uncertain. So there's uncertainty about the security of this work. There's also, we are challenged with where this strategy actually sits in terms of its governance. It reports to the Health and Wellbeing Board, but it's at the moment there are some challenges within the ICP and the mental health, where we should actually go and be focused on the governance for it there. But there are some opportunities to align the practice within the wider Central East ICP cluster. So thank you, and open to questions.
Thank you, Kathy. Thank you, Richard. Any questions from the board, please?
Thank you, and through you, Chair. Thank you very much. It's a very interesting report, and I have two questions. One is about the data. So the data in the report that we received doesn't relate to the latest suicide prevention strategy, and I was just wondering, what does the data say about preventing suicide? Have we been successful? Was the previous strategy successful? And you can't really tell that from what's in the report. And my other point is that I didn't know about the bereavement service, and just messaging a colleague now in my council, she didn't either. And she's the person who would normally receive calls from people saying somebody's died. And I think there was a piece of work to do with district councils promoting that bereavement service, because it sounds like a really useful service, and I don't think my colleagues know about it.
Okay, can I answer the second point first? So the bereavement support service is people are referred almost immediately when a death occurs. So when the police usually initially support the bereaved person or the family, they ask if they want to be referred to the bereavement support service. It's a direct referral then from the police to that service. It's not usually from any other sort of route. That's that direct, and they have capacity to support the next of kin, and so that immediate family member. And it's very, it's very difficult to offer support to a broader number of people. And we know that many people are affected by suicide, of an individual suicide. So the amount of funding that we have is for literally the next of kin and the sort of very close family. So the referral route is directly via the police asking if they want to be referred. But having said that, there are opportunities to be referred, and they have that conversation with Lifecraft to have that direct support. But it's like Richard said, it's sometimes quite a long process. They hold people and support them for quite a long time. And so the capacity, and it builds and builds as more and more people are added to it. But yes, certainly we could promote it more, but that is the kind of route for it. And as far as the data, we track, both Cambridgeshire and Peterborough track within the, so it has, because there are small numbers, it does vary quite a lot year by year. So it's very difficult to put statistical kind of measures around it. But so there have been periods where it has been below the England, statistically significantly below the England rates for suicide, but at the moment it's tracking along that the England average. So we're not sort of worse or better than England. And I think recently we've seen a slight uptick in suicides, And certainly with Peterborough, actually, historically, we have had significantly worse than England, and that has come down to being in line with the England rates. But Peterborough tends to track slightly above the England rate, and Cambridgeshire, the rest of Cambridgeshire, tracks slightly below it. There are differences between districts. Fenland is worse usually than other districts usually, but because of the small numbers, it's quite difficult to put those rates around.
Thank you. Kate, do you have a question?
It's probably an offer of support as much as anything. I think this is such a very, very important topic, but it's such an incredibly complex, interrelated, bearing in mind we're all here from different organisations and we will touch our population in different ways. Having come from my previous role in the Ambulance Trust, where we were covering the entire region, the amount of information that is held in some parts, same for police, it's how that interrelates and how we can kind of get support up front for our population who are tipping into a space where they need that additional support. And I think what would be good to talk through, or to work with Erin and John behind you really passionately on, is making sure that from the very beginning of this work, so the post that you are recruiting to is brilliant. It's great you've got funding for that. Could that have been a joint post? Could that have been something that we could have been thinking, is there an element of where we need to almost physically start to reduce the gaps between our organisations to be able to think, actually, how do we come together to wrap around the population in a much more holistic way? And I would really encourage you to make sure that you do have all the, I'm sure you do, but all the partners around the table, like forgotten ones who are often people like the ambulance paramedics, who see an incredible amount in every visit, because there is also a clear pattern of behaviour that often there is nowhere to escalate the pattern of behaviour to, which is really why the neighbourhood model is so important, and how that kind of all knits together is probably definitely our collective responsibility. So an offer of support, happy to talk to you about it a bit more, but I would highly recommend sort of leaning on the partnership model to kind of amplify the work.
Yeah, that's exceptionally useful. And yes, we are growing that partnership. We do often have ambulance join us as well. And also the post is actually across Cambridgeshire and Peterborough. So it's funded by the ICP, but it sits within public health across Cambridgeshire and Peterborough.
Thank you, Neil.
Thank you for an excellent paper and sort of canter through this agenda. I think definitely, so as a GP in Peterborough, we see a lot of people who are very low. We see a lot of people who have got ideas of harming themselves. And certainly, I think, one thing, building on Kate's point, is about the integration, because actually, look, the voluntary sector provides a lot of support for people, but actually, how good is the communication between GP practices, primary care, and the voluntary sector? Where are we working together on this agenda? Where we're kind of, a 10 or 15-minute consultation is good, but on top of that, then further support by working collaboratively with the voluntary sector would make a huge difference. And I think, again, not in a trying to be critical way, but I guess a key plank to this, I think, is if you think about the data, it's in Peterborough, it's in Fenland. So, we've got policy across the Health and Wellbeing Board, which is brilliant. It's great to have a strategy, but then the implementation has got to go down to areas, because actually it'll be different in different parts of Cambridge, it'll be different in different parts of Peterborough. So I guess, building on the previous direction of travel, as we write chapters about strategy, I think it's got to include neighbourhood-based working. It's got to be, and I guess having an MDT across Cambridgeshire, having sat through many MDTs across Cambridgeshire, one of the real difficulties is, well, how is it about my population? How do I make a difference? And the way that we make a difference is through our neighbourhoods and through our communities. So having a strategy like this is really important, but we have to have the discipline then to understand, well, how do we go from having a really good strategy, and how do we get that? How do we build into the strategy the need to implement that in localities? Because that's what's going to really make a difference to people and populations.
Thank you, Neil. Yeah, Sally.
Thank you. Completely agree with Neil's points. I think that those are really important. And then the other point I wanted to make, I think it's a great paper, and there's loads of really fantastic work gone into this. In the run up to this board and reading the paper and all the great work, it did make me reflect on how visible it all is. And I'm going to make another point around governance, and which is made a point. My last comment about governance. I'm not hung up on governance, honestly, but there's a really great partnership group for this work. But then, where else does it go, and how else do we make it go out to others that need to know about it and get the right action? So, is there somewhere else that should? Have we got the governance right, or is it just around working better with neighbourhoods and getting it out there, or is it just people here? Going back to the point of this board, I guess, really being cited on it and having that ownership to then take it out to their organisations. So I think we just need to think about how we increase the visibility and strengthen the actions around it through possibly governance, or just us all kind of taking it forward in a different way.
Thank you, Sally. Patrick.
Yeah, thanks, Chair. I just think there's, in addition to that, I think there are other conversations taking place, and we should be mindful of the role that they play in that. So the community services review that's underway, I think we've got to really think about the opportunities that brings to do much more preventative work. I think we've got to think more, not only about place for us as statutory organisations, but our communities and our conversations that we have at a much lower level with district councils and with our voluntary sector organisations and the population themselves, and engage them more. We've just concluded the second quality of life survey through the council, and we still continue to see real high proportion of people aged kind of 18 to 24 really displaying low mood and saying they've got suffering with mental health. And I think we've got to find ways in which we then start to engage with that core population through plays, but start to understand what more can we do at a much lower level. This isn't all about all partnerships doing something. There's something about the lower level as well, to try and tackle it that way.
Thank you, Patrick. Yes, please, Paul.
Thank you. Really good report. It's very self-reflective and it's clearly generating conversation, which is the sign of a good report. Thank you. And thank you for what you're doing. Another statement and a question. So the constabulary will commit and continues to commit to our mental health coordinator role, which plays that key kind of link between the coronial service and frontline suicide. Sally spoke about governance, and I would completely agree. There is that need for neighbourhood offerings to understand the root causes, of which this is key. But equally, in terms of strategic governance, we've spoken before at the tactical group about that important link between our strategic groups, specifically the mental health strategic group, which is at best at the moment very unstable. This is a preventative piece of work, which is awesome, but we do need to link it to the operational delivery and the front end of mental health services, so we can get upstream of some of the other really difficult challenges, changes in legislation, changes to finance, changes to the kind of the way that ambulances and ambulance service and police deliver frontline mental health services, which will have a long-term and an immediate knock-on effect. So in terms of reflecting in your report and your recommendations around linking systems, it's that key link that we need across to the mental health strategic group as that reforms as well. Would please be my ask of this, but thank you for what you're doing. Much appreciated.
Thank you, Paul. Anyone else? Graham, yeah, if we can go Graham and then Raj briefly, because we are over the time of this.
So, very briefly, just in response to Sally's comment about increasing visibility, there is going to be a debate on suicide prevention and awareness raising at the full council meeting here on the 21st of October. So that will be an opportunity for us to talk about the different aspects of the suicide strategy and what the council can do. Thank you.
Thank you, Graham.
Right.
Thank you. And firstly, thanks to Kathy and Richard, because I know a lot of work has gone into this. So a lot of work has gone into it, and thank you for such a succinct report. I know from talking to you both that the transient and interim funding for the suicide prevention manager is an issue because it only gets renewed annually or every 2 years. And so is there commitment from the board that this is important and we need to fund a suicide prevention manager in a sustained sort of way who acts across the system and makes those links not just with the strategic mental health partnership but also with primary care community? It's a complex web of people they have to interact with and get together, and right from strategic to operational level. And do we as a board think that find the resource to fund this post?
Thank you, Raj. Yeah, thank you very much, Kathy and Richard. That is an incredibly important part. I will reserve my comments. I had a couple of comments on priority risk groups and data and how we slice that and how can we monitor and prevent in advance. But I'll save those probably to an email to you because, yeah, your work and surely the response that you'll give me is lengthy. So thank you very much. And I welcome Jan Thomas, Chief Executive of the Integrated Care Board. She just joined us. Jan, welcome.
I'm incredibly sorry for being late. A bit of a clash of meetings, so apologies.
Great to have you. Okay, thank you. Mike, yeah, if you want to be brief.
I'll keep it brief because I keep it brief because I gather you want to move on, Chair. But I did feel from the local mental health provider, I ought to just say something. And thank you very much indeed for the report. Strongly support it. Catherine Faulkner, who's one of our public health consultants at CPFT, has had a lot of input, and we are fully behind it. Just 2 points occurred to me. One was you did bring out priority number 2, which is the treatment of people with severe depression. And that is an important aspect, I think, of suicide prevention, but it does present challenges. You've also said that resource is an issue. And at the moment, our virtual ward for clozapine treatment is only reaching about 25% of patients who are eligible. The provision of lithium treatment is limited because we don't have the ongoing pathology support to monitor lithium treatment. So there are sort of practical issues which need to be addressed in terms of achieving your priority number 2, although all the priorities are important. So I suppose all I'm saying is that from a CPFT point of view, we're right behind this, and it does feed through on a regular basis through our Quality and Safety Committee, learning from deaths. So given that 60% of the suicides are people known to mental health services, this is a serious commitment by CPFT, and I'm grateful to you not only for the report, but if I may, the sensitive way in which you approach this, because having met many families who've suffered from suicide, it's not only bereavement support, but they want to support the service changes that will help other people who find themselves in this difficult situation. Thank you, Chair.
Mike, thank you. I think we are unanimous in the support and yes, making sure that we, from our collectively or in our capacity in the different bodies in which we work with, to make sure that they receive the funding, because I think we are all in agreement this is a problem that will only be exacerbated with modern times. Members, do you have any other questions? We will move to the report recommendations. We are being asked to consider the suicide prevention strategy for 2025-2029 and endorse the priority areas for action. Everybody in agreement? I will take it that we are happy to support this recommendation unanimously, unless anyone dictates otherwise. We move forward. Item number 5 is an employment and health joint strategic needs assessment. This report will be introduced by Val Thomas, the Deputy Director of Public Health for Cambridgeshire. Val, welcome.
Coming in.
When you are ready.
I think I'm being joined by Ian.
Hi. Are you?
Ian's Peter,
Okay.
the City Council, and I'll leave him to introduce himself. Okay,
Yes, I'm Ian Green. I'm a service manager within public health at.
Ian, if you thank you.
Yeah. Yes, I'm Ian Green. I'm a service manager within public health at Peterborough City Council, and I'm leading part of this work for the City Council. So I'm the public health lead for employment and health.
Is everybody happy if I share my screen as well? I'm not going to go through the presentation, but it might be helpful for. Okay, so I didn't do it. I didn't. Try and do it. I am feeling the pressure, Kate. I am definitely having asked, can I share my screen? And then I'm failing miserably. Share. It should just share. I'm sharing, but it's not working. Do I? Let me back on. Okay. I was excuse me. Go back to there. Get rid of this. Cancel. Put my camera on. Right, I'll try again. No. It's not showing, is it? Won't let me share, I'm afraid. I know, Monica, I just put me on screen. Pardon? Oh, aren't you lucky?
Any red hologram type?
Do
you want me to help?
Yeah, please. Because it won't let me share.
Well,
no, that wouldn't be pretty. It's not. It's on screen there. It's not working.
Is it because it's already in PowerPoint?
Yeah. But it won't show on the screen. It won't let me share. Try there. Try that. Right. Maybe.
Yay. Well done.
Well, thank you. I don't know whether I'll try and take it off because I've got the full screen here. Are you happy having the slides down the side? Thank goodness for that. Right. Okay, I feel as though I'm doing a double presentation here because this JSNA is a guinea pig for the new format for JSNAs. And this came from a lot of discussion that usually JNAs are quite lengthy documents. So the proposal was to let's try a different format, and this is in a slide set. It focuses on bringing the relevant data and then clear recommendations that are backed by some evidence. So this particular JSNA contains the data. It contains some evidence, and the data is both quantitative and qualitative. We did some lived experience surveys with employers and with service providers such as education providers, a whole gamut, as well as looking at the hard data. And we brought the recommendations to the beginning of the report because I think that's probably where the focus lies. And also, there were, about 19 recommendations initially. So we themed them first of all, and then pulled out 4 overarching strategic recommendations with what I've called deliverables underneath rather than objectives, because I think that's what we were about, delivering rather than having objectives. I think there was a couple of queries about that, but I think there was a reason for that. So any comments back on the colors, brightness? Very welcome. A little bit about the context. I think work and health and the importance of health. It's importance of work rather. It's a determinant of health, but it's more than that. It's intrinsically linked to good health. It's life affirming. It gives people identity, and in the workplace, it gives people a social context. And it hits so many aspects of health. And I think one of the slides links areas that have low economic activity, high employment rates with healthy life expectancy. And there's a clear link between if you live in one of those areas of high employment, you've got better healthy life expectancy. The other, I think, contextual bit is the national context. There is a lot of focus nationally on work and health, driven by a number of things. From obviously growth, impact on benefits, and also a health agenda as well. So I think this JSNA is very current. It was, again, another contextual thing. It was driven by a request to look at economic inactivity, but I think we've broadened it out to look at sort of employment and health. Health is a factor in there, certainly, but it's very complex. People out of work often have many complex problems. Health perhaps is the immediate one, but behind that, since it's many, many issues which are socially driven. So it is a broader JSNA in that sense, not that sort of economic activity in health, but looking at the broader picture. The sort of key themes that have come out of it: health inactivity has increased post-COVID. That it's very much linked to people with long-term health conditions or disabilities. And I think I pull out learning disabilities, particularly in that category, but it's also linked to people who have caring responsibilities. That might be also looking after families. And it's linked very much to actually to sex as well. You have more women economically inactive than men. Then I think another sort of key factor in it is other causes. As I've already alluded to health, but it's that complex mix, going back to that complexity of health, education, skills, and absolutely cutting across that are the disparities. And you can see how economic inactivity plays out across geographies and across certain groups. And we tried to bring that out in the JSNA as well. And I'll move on now, and this is when I'll move the screens on to the, it's not moving on down there, is it? Well, I think probably you have the paper. And so I'll go through the 4 strategic ambitions and, nope, won't work. Hide that, see if I can do it that way. Nope. Right, okay, back to the drawing board. In the papers, the 4 strategic ambitions identified with their deliverables sitting underneath. And I think the deliverables, you can link them to certain organisations in the system. And I think the first strategic ambition is, sorry about that, that's my phone. It's the the added value of working at that system-wide level and the interconnectivity across the system. And so, for example, the first deliverable talks about Work Well, Connect with Work and the Youth Guarantee Trailblazer. And I think we've been incredibly lucky in Cambridgeshire and Peterborough to have those very active. And it's really tested out how we work as partners across the system. And I think we have very active partnership groups in various parts of the system that are taking this work forward. But there's much more that we could do by maintaining and complementing this existing work. And so that strategic ambition to address the multiple and complex barriers to employment, it's just that continuous drive to expand this system-wide working and cross-sector collaboration. And it includes a multitude of services ranging from obviously health, but employment support, social care, education, skills. And that sits alongside that sort of growth and infrastructure agenda. And given that both Cambridgeshire and Peterborough are one of the fastest growing areas in the country in terms of local growth and population growth as well, it's absolutely key that we have that holistic approach. And then just to throw in another complexity, which I put, if you have it open, the organisational landscape is changing. And as we change, it will be so important. And I think this has been picked up earlier to maintain that those collaborative developments. And there are 6 deliverables there, and I'm not going to go into them, but an example is, for example, development of local data sharing agreements across health, education, social care and Department of Work and Pensions to enable a personalised integrated approach to support. We've come a long way from where we were, but we could do much more if we had better data agreements. And some of this is driven nationally for DWP. But I think it's that system-wide thinking. With this data, we could do so much more. And then employer engagement programs, for example, ensuring that we have that join up between education, skills and health with the employer engagements. And I think working with employers is a key theme throughout all of this. So I'll move to the second strategic ambition, a very persistent cat. And this is very much taking the preventative lens, targeted and to address the employment disparities, which I sort of briefly alluded to at the beginning. And this, I think, I'm going to home in here, for example, for I think probably on NEETs, young people aged 16 to 24, not in education, employment or training. They are probably one of our priority areas, especially so for Peterborough, where NEET rates are especially high. I think in Cambridgeshire they've stabilised and absolutely plateaued and below the national rates, but still at a rate which is not acceptable. But I think thinking through the prevention lens, there's a lot of evidence to say that you can identify children and young people at risk of becoming NEET. So it's about shifting the focus. Don't let them get to NEET. Focus on those children and young people who are at risk of becoming NEET. And picking that up and all those deliverables, it's very targeted and it's very preventative, this particular strategic ambition. And then thirdly, focusing on education and skills. Again, there's under the Make Britain Great, not Make Britain Great, sorry, let's Get Britain Working Again. I've been listening to the news this morning. Get Britain Working Again. We have lots of initiatives about strengthening the offer, both in education and skills. And again, it's building those opportunities into work well, into other services that support people back into work. And then the fourth strategic ambition goes back to being in work is enhancing, health enhancing, and it's creating those workplaces that that promote health. And then again, I think probably one of the things that strikes me as you look through the data is that we have low-paid, low-skilled workplaces, and there's evidence to say that you have poorer health outcomes from those workplaces, reported health outcomes, admittedly, but it's how do we work with those employers and those workplaces to ensure that they not only give people the opportunity to progress and to grow, but also to make the workplace a healthier place to be. And we've talked for a long time in Cambridgeshire and Peterborough about introducing the Good Work programme, which would be the combined authority-led programme. And I think it's a specific recommendation to take that forward now. So I've just run through the 4 overarching strategic ambitions, touched on some of the deliverables that sit underneath it. I think there's too much information in the JSNA to present in a forum like this, but I think for me the absolute core theme is to build on what we've done already in the system in working collaboratively across health, social care and the combined authority skills and education, and building on that to make sure that we take it forward, strengthen it. We know there are lots of things that need to be strengthened in the system, and at the same time not least that work with employers to continuously improve how people work and how they work and where they work. And the recommendations are for the board to consider the overarching recommendations and the implications for the system of some of the deliverables of, well, all of the deliverables, and what you think would be our priority deliverables where the system can bring added value.
Thank you very much. Well, that was the most interactive presentation we have had in a while. I was just waiting for the smoke machine. So, Ian, would you like to? Yes, we are.
Val, can you just stop screen sharing so that board members will be on the screen? Thank you.
Thank you very much, Rishinda. No, it's working now. It is now. No worries. Do you have any? Are you going to use of the screens, Ian?
No, but I'll just come in and with one point. And I think the other important bit is there's a lot happening across Cambridgeshire Pitch at the moment, whether it be Connect to Work or Work Well or Get Everything Working. And the key is to bring all the different bits together into one place. So we have a one view of what's actually happening, and we all can play our part in that system because there is a lot happening locally at the moment.
Thank you very much. Board comments, questions? Neil, Mike.
Yes, thank you. Thank you very much indeed. I'm Mike Napton. I'm one of the non-execs at CPFT, so I'm obviously coming at this from a mental health point of view, and I absolutely take the point that part of the recovery from serious mental illness is getting back into work, and it's very important. So can I just call out a couple of CPFT services which I think play into this? One is the individual placement and support service, which is Treasury funded, not NHS funded, but hosted by CPFT, and that works with both people with serious mental illness and employers to help employment, but also retention. So when somebody has a relapse from their mental illness, they can work with the employer to help them through that. And it's not just depression, psychosis, but learning disability. However, the funding of that is Treasury, not health, and needs to be secured. And there is an ambition to expand that service to primary care referrals, but at the moment that's not possible because the funding has not yet been secured. So I think that's one point. The other is our neuro rehab service for children with major head injury as they move and transition into the workplace. That service is providing, I think, support which will play into your agenda. So absolutely support what your recommendations from the point of view of someone who works in a mental health trust. So thank you very much indeed.
Thank you, Mike. Neil?
Thank you. Thank you for the slides and the new presentation. I really like the style of that. I like the sort of the delivery section as well at the back, because I think it's about keeping ourselves attuned to the fact that we are delivering, on this stuff already. I do think there's a massive area of opportunity with this area of jobs, and definitely, if I look at the progress over the last 2-3 years in this area. Now, the area that I work in is one of the highest areas of both employment, but also giving medical certificates to people. And so because of the nature of our working age population, and now the amount of different ways we can support people has, completely increased. So we've got job coaches, we've got work well programs, we've got citizens advice, all co-located, and actually that's made a huge difference for our population. But there's still more opportunity. So actually, and some of these opportunities come through still our silos. So there are health opportunities, there are mayoral opportunities, there are council-based opportunities, and I think the opportunity is this is an area of massive potential for integration. So in terms of which priority to pick, I think the priorities you've chosen are all really sensible priorities, and I wouldn't want to say which ones are priorities of the others. But yeah, thank you for the paper and for the work in this area.
Thank you, Neil. Yes, Stephen.
My point's actually very similar to Neil's. I just wanted to say I really like the format of the JSNA. I think there's an awful lot in there, isn't there? And presented really well through the medium of comedy, I think, as well, isn't it? Yeah. I don't think there are usually enough cats in a presentation, but and I think my point is very similar to Neil's. It feels as though this is it's such an important area, such a major area for us. And there is so much work, I think, going on across the areas, isn't it? So I think within Peterborough, we have quite big transformation programs going on around employment and skills. We're trying to coordinate, I think, within the council, work that's going on across the council. But there is so much going on, I think, in different pockets. And I think, as Neil said, within silos. I wondered whether, and I think that you've done a little bit to sort of bring together some of the parts of what's going on. I just wonder whether there is some kind of quick and dirty exercise we signed up to really kind of understand what's going on, all the opportunities, all the schemes. The work well stuff is really good. Are we really making the most of it at the moment? I suspect not. I just wonder whether we wanted to do something to coordinate and pull together that bit just to really understand the work that's going on, especially as we head towards kind of LGR, and I know the district councils will be doing loads in this area and stuff as well. it just does feel kind of very disparate and lots of quite major bits of work going on. And I think Ian touched on it there in terms of the coordination bit, but do we want to do that quick and dirty bit really in terms of just understanding the full scale of work that's currently going on?
Very much, Stephen. Kate.
Well done, Val. I think that was, I love the way that this is a much more accessible report. And this, to me, is such a fantastic example of where we've actually managed to build an integrated delivery model. I take your point, Stephen. I think a lot of the answers to your point are in the documentation. And I think the amount of work that's gone into kind of pulling all the various strands together, and our combined authorities' role in that has been really key. In terms of how we kind of knit it together and take it on to the next level. I was going to make a broader point, which I think is really important when we think about our kind of economic footprint and growth agenda, that we need to make sure that we're also really working, which I know is in there, but with our employers to make sure actually they are in a position to support these programs of work, and actually they are supporting our economy. Liz and I were talking about this earlier as well, but I think that it has to be a key component of how we're bringing the broader population on the journey, the people that we're trying to help, but also the people that actually are providing the kind of opportunities for those individuals as well.
Thank you, Kate. I'm going to have Jan first, and then Sally, and then Liz.
Just a couple of questions, actually. So, firstly, across health, social care, local government, police, fire, all other partners, we employ a huge amount of people, and there is something for me about us. We need to be explicit about. We are anchor institutions, we are anchor employers, and what commitment are we making as employers in order to address this? I know it talks about working with employers, but we have two roles here, don't we? We have a role as encouraging and working with employers, etc. But we are also large employers of humans, and therefore, what steps are we taking to make sure that everything that we are doing is able to do that? The second question I've got, though, is just when we do things in bits, which is kind of what we're doing now, we end up spending quite a lot of money on doing bits. Do we have any analysis on how much we're spending on all of the bits now that we have landed in here? Because and who is spending what and who is putting in what investment? I would quite like to understand the investment profile. So who gets the return, who's making the investment, and how are we seeing that? Because we can't just keep saying this is what the data says. We've got to start looking at the health economics and the wider economics of it. So I wondered if you had any view on how much are we spending on doing. It's the right thing to do, by the way. This isn't me questioning, are we spending too much? It's almost the reverse, which is, are as individual parties, we all playing our part in making the investments we need and allocating our budgets in the right way to this. So do you have a budget analysis that goes along the description of the problem?
Thank you, Jan. Sally.
Thank you. I'm conscious that the presenters are scribbling lots and lots of answers to all the points that people are making, but I think it's great that everyone's so supportive of the work. And I think I just wanted to make the point that all of these bits are really well connected through this. I think it's a really good example of where we're starting to make these connections in a really good way. So this is the needs assessment, but actually, I'm going to make a governance point again. There is a strategic group that brings together all of those different component parts, and this needs assessment is forming the basis of that work plan, which I think is quite novel. We're managing to get that right now, and an opportunity to obviously build on it and improve on it. And I think Jan's point is really well made as well. But all the work well, the connecting for health and all of the other bits are all coming through, working with the combined authority as part of that work, looking at the work and health agenda led by this needs assessment, which is fed into the Get Britain Working plan. So it's all starting to connect in a really positive way.
Thank you, Sally. Liz, and then we'll probably get back to Ian and Val to wrap up.
Thank you, and through you, Chair. I'd like to say a huge thank you to Val and Ian for this work. First of all, I think the new GSNA kind of presentation is really clear and much more accessible, so that's great. I think I shared Jan's concern around the bits. I think we are driven by funding, and I'd like to express a frustration that we have, a handful of pilots, and at some point, I think as a system, we need to think about, are we committed to investing in longer term kind of ongoing projects? Because otherwise we just keep being kind of thrown these pilots by the government and we keep responding to them. And that's what's happened, in my view, with Connect to Work, Youth Trailblazer and Work Well. Notwithstanding that, I think you've done a brilliant job to join everything up. So that's great. That was my rant over. My kind of, I suppose, substantive point, and I think one of my colleagues has been talking to you a bit about this, Jan, is about employers. And there's a lot in here about the experience of employees and the experience of the education establishments. And one of my colleagues is quite keen to understand a bit more about the barriers that employers experience. And I'm not sure that I'm pretty convinced that there's probably some good data out there that we can use rather than initiate our own piece of work. But that seems to be just a tiny bit of the jigsaw puzzle that's missing, if I may suggest that.
Well, Ian, if you would like to be brief and just wrapped up, or
But no,
you have any comments?
I'd like to
Go for it.
say something, please. I think the comments above from Mike from the Mental Health Trust, I think IPS is very, very involved in Connect to Work, and we work closely with them. So, but it needs expanding. I think that's a challenge. Definitely. Look, it's evaluated so well, and I've seen it have such impact and traction on people's lives. So I think it's well made, and it's something the system to do to support that. I think would be extremely helpful because it does evaluate very well. I think there's something about the scope. Yes, I think we have done a lot of scoping, and I think Kate picked up on the point that as well. But just to say that I think you can always scope, you can always miss. And I think the idea, I think, is that you must keep on going because there are always new initiatives, there are always new people that you can pull into the circle. So yes, it's not sort of work in progress. It's kind of an ongoing challenge to make sure that the right people are in the right place at the right time. Then there was something about, I think, anchors, yes, and I think we've sort of started, we have a paper later on anchors, and I think we started to see them develop, but they have fantastic potential. But I think also with anchors is that the principle is embedded in things like apprenticeships, and so I think it's actually thinking role of employers, no matter what they're called. And I sort of saw the JSNA 2 from the comment on the cost impact and the cost benefits of all of this. It's almost like the next stage. We've got national figures about you put in X and you will get Y out, but in terms of having a local profile is a piece of work that I think would be extremely helpful. But I think the whole arena around employers is a challenge, and it came out repeatedly. I think Kate behind me, who did some of the lived experience and interviews, would bear witness to this, that it was a theme about there seemed to be a dissonance between what was coming from what employers said and what was being said by people with lived experience. And it's not so much by intent very often, it's because of the challenges are not fully understood. So I think that piece of work, and I think I know the piece of work from your team that we've been talking about, I think is one piece of work, and I think the combined authority are about to do another piece of work as well. But it's how we gain that traction and interest and engagement of employers in a way that they see as being helpful and beneficial. And some of the research that's come out of the North has been about almost saying, it's employers, you are part of your community, you drive your community, you have ownership of your community, you have a member of your community, and you have that social responsibility that goes with that. And that's worked very well in some of the big employers in the North that's come out. So I think it's another way of looking at it as well. So I think that's probably one of the challenges that came out time and time again. They are almost like the elephant in the room. We talk about X, Y, and Z, but actually they are the people that are fundamental to it all. So Ian.
Yeah, nothing else to add from me. I think we've covered the main points. Just one small point actually is this bit about how much do we spend. We have little bits of that information, but we haven't pulled it together. So I know what we're spending in Peterborough City Council on some of these employment work, but we don't have that across the board. So it might be helpful to look at that for a future time.
Thank you very much, Ian and Val. Yeah, that might be an exercise that we can do, and
Yes,
we
I
can
do, yeah.
all get to the bottom of exactly how much collectively we are spending. Kate, yeah, you can make your point. Yeah.
Can we take that as an action? Because I think that would be a really
I think it
healthy
is an important one.
exercise. Yeah.
Yeah.
And I think there's probably a broader action which also covers our suicide conversation, or where we're looking at these topics. We are all spending, as Jan articulated well, in that space. So I think for this sort of, from a governance perspective, Sally, for this board's purposes, I think it'd be really helpful to be able to kind of quantify that.
Sorry, Val, can you
Val,
put your
please.
microphone on?
Sorry. I think the sustainability, that type of analysis will help with the sustainability as well, because I think you mentioned work, Liz, I think it was Liz you mentioned, and I think we're really pleased to know that Workwell is going to be extended. But, you know, there's so many of these things, I think, that that by doing that type of analysis would enable us as a system to look at what we invest at the moment, what we would need to invest to have even better improvement in where we want improvements in our employment profile.
Thank you very much. Yeah, it's a incredibly complex and huge topic. I am an employer personally, and for 20 years I've been in this country, and it's yeah, hugely complicated. We will move to the report recommendations. We are being asked to support the following in the Employment and Health Joint Strategic Needs Assessment. A, the strategic themes and findings, and B, the priority strategic recommendations and their deliverables identified in the JSNA. Everyone in favor? I will take it. The board is happy to support these recommendations unanimously, and we'll move to the next item, which is item number 6. Thank you. Thank you, Ian. Item number 6 is the Cambridgeshire and Peterborough Anchor Partnership Update. This report will be introduced by Jessica Brocklehurst, and the Deputy Director of Strategy and Innovation at North West Anglia NHS Foundation Trust, and John Taylor, the Corporate Director at Huntingdonshire District Council, alongside Katie Hartley, a public health consultant, and Peterborough City Council.
Can you hear me? Am I on okay?
Perfect. Yeah,
Brilliant.
Please go ahead.
Thank you for the introduction. So I'm Jessica Brocklehurst here on behalf of North West Anglia Foundation Trust and representing alongside colleagues the Anchor Steering Group. So we brought a paper about Anchor to the Health and Wellbeing Board back in March. And we're here really to present our progress since then. But I think it's fair to say that there's been an awful lot of change across local government and the NHS during that time. And as a group, we've had to kind of pivot and evolve our approach. But really being an anchor in the community is all about delivering our core business in a way that adds greater value to local people. And I think some really nice synergies with the earlier JSNA presentation that Val gave. So being an anchor includes supporting the local economy, for example, by pivoting our procurement spend to buy more local wherever possible. It's about providing jobs, supporting job creation through thinking about our recruitment practices and how we can make sure that we're providing local jobs for local people and how we're supporting local people to develop their skills and employment potential. And I think that really ties nicely into that JSNA item. And I think our Anchor Steering Group is one route to making sure that the various health and work initiatives are knitted together across the system. Anchor is also about sharing our assets with the community, whether that be opening up our spaces to local voluntary sector or faith groups, for example. And it's about doing what we do in a sustainable way, so an environmentally sustainable way, looking at our carbon footprint. So Anchor is quite all-encompassing, but I think presents a huge opportunity for us as a system to make progress against a number of kind of adjacent and overlapping themes. If we get Anchor right and we collectively capitalise on the opportunity to be Anchor organisations, it can help us to reduce inequalities locally, to drive that economic development that we know is so important, and to drive that health and work agenda as well. So since we last brought the Anchor item to the Health and Wellbeing Board, within the NHS, we've had the 10-year health plan and the DASH review published. And both of these documents, I think, really help to add focus and drive Anchor as a real priority across NHS trusts in the area. So both documents talk a lot about NHS organisations needing to be community anchors and their role in that local employment. And we know that going forward through CQC and other oversight regimes, NHS trusts are going to be held accountable for this going forward. So it will no longer be a nice to do, it will be a need to do. And I think that's really helpful for us. So as NWAFT, we've been doing two things really. So we've been looking internally at what we can do better and more of. For example, how we can go even further to bake social value into our procurement processes. We've been looking at, with colleagues at Huntingdonshire District Council, how we can strengthen links between Work Well and Job Centre Plus with our kind of recruitment teams and making sure that we're kind of capitalising on those opportunities. And using our apprenticeship levy, exploring the use of our apprenticeship levy to drive skills locally, not just within NWAFT, but across the patch. The second thing that we've been doing as NWAFT is playing a sort of system leadership role. So we've helped to set up the system-wide Anchor group and helped to sort of facilitate and coordinate that group. And since March, we've been really focused on formalising that group, getting support from partners, setting up the governance, supporting partners to get internal support within their own organisations to sign up to the Anchor Charter. We've agreed a set of baseline metrics that all partners will go back and collect so that we understand where we are, where we're building from, and making sure that we can kind of capture our impact going forward. And we've been learning from others outside of the system to understand and inform our approach going forward. So I'll hand over to John now to give the local authority perspective.
Thank you. Nice to see some familiar faces and some faces I'd like to get to know better as well. So nice to meet you all. My section really is just to try and make this real. So the principles that sit within the Anchor strategy and approach are absolutely valid. I think I'd put forward from a district council what this is about for us is about pivoting and doing what we're already doing and making sure it's really aligned within this space, but also looking for new opportunities. So as a consequence of this work on Anchor, and we're also looking at our procurement strategy and approach to make sure that we spend money in the right way. It's about reinforcing local businesses, but it's also getting that social value payback from those organisations that we buy goods and services from. So there's lots more that we can do in that space. We also have got our own workforce strategy. That's got a real key plank around recruitment and retention for local people. So our activities around that are focused on our area and what we can do to help people from some more disadvantaged communities get jobs and work with the district council and have careers that last with us. We're also using our work on the Work Well programme, again, as we mentioned so many times already this morning, but it's a real example of us connecting into different sectors to have the right outcomes for people in terms of work and long-term prospects. So practical things are happening within the patch within Huntingdonshire. We also do a lot of work on kind of enabling communities to do stuff for themselves and help them support them through that. So our own local health and wealth strategy and fund is now live.
We're supporting local organisations with direct funding to deliver initiatives that they believe will make the right impacts in their area. The strategy and approach for that is sat around doing local social benefits, employment, housing. It's those wider social determinants of health that are rewarded through that scheme that we're trying to reinforce locally. Not lay down solutions, but actually enable communities and support them to build their own solutions. And Jess is right, the work with NWAFT has been fantastic. Lots of opportunities with that new hospital in our patch. Lots that we can do to make the most of that facility, to co-locate, have officers working alongside staff from the NHS and vice versa. So we're looking at our own leisure centres as well, and what can we do around having space in there that we can dedicate time together to help the needs of our communities. So real concrete products and things that we're actually doing. And the last aspect, I guess, that the District Council is doing as a consequence of the anchor-based work is just reflecting on where we can influence activity as well. So working across the broader sector is really important for us. But it's practical things like working with local businesses. We've got a very good and very active economic development team who talk about jobs and skills, obviously with those local businesses. But they also take along representatives from our communities teams who talk about the work that our teams do locally with groups around employment, around skills, about helping people get into work. And we're trying the very best that we can, actually seeing some really good signs already locally that local businesses recognise the value in that. For them, it pays back to have a great community, to have people working in. It gives them the kind of workforce that they need. So the District Council has done a lot of really quite, I think, practical things to really make a difference from that anchor perspective. So for us, it's been a really positive step forward, something I really welcome and we'd like to do much more of. So there's some examples. And I think we're going to round up now and take questions.
Yeah, I just wanted to also say that from Peterborough, I obviously represent Peterborough City Council, and you know, I think it's such an important initiative for Peterborough City Council to join the anchor partnership to very much drive that economic development for Peterborough City itself. And from the perspective from public health, that's really around addressing poverty, and also from some of the conversations we had before about linked to economic inactivity, how we address that, and also mental well-being, how we support mental well-being of our own workforces as anchor institutions and have that set that good example. So the ask from the anchor partnership is really for the board to support the approach of the anchor partnership, how we strengthen that approach, how do we get the partnership to really form and drive through and join up and add more value and endorse the approach, how we prioritize. Do we want to prioritize some of these pillars of the anchor pillars? You know, is there a particular area that we want to focus on as a partnership? And how we consider our resource as a partnership to really drive this and the momentum, for example, through endorsement and support for program management of the anchor partnership.
Thank you very much, Jessica, John, and Katie. Members, do you have any questions or comments on the report? Yeah, Liz, please.
Thank you, Chair. John, I think it would be great if you could bring this to the Public Service Board, because there are certainly districts and possibly the county who, I don't know if you're signed up to the anchor partnerships.
Beat my point.
Oh, I beat you to it. I think there's more of us who should be leaning into this and who probably would be very keen to. So maybe could I ask you to come to the Chief Exec's Public Service Board and do a presentation about what you're doing. Thank you.
Thank you, Liz. Yes, Patrick.
Thank you, Chair. Yeah, I'm not sure the County Council's been that engaged in it. I could see in the paper that it says more recently, and I do think that as statutory organisations, you know, we should all be committed to that. And I think broader than just the County Council, you know, priority one is around young people, and I think we should be looking to education. There's lots of academies in the county, and I think we should be looking for other employers who can both work with young people but also attract people to go and work there. So I think there's a significant role there to play. I think in terms of how we look at this and then the previous item on the JSNA, I think we've got to make sure that we don't end up with, as Jan described it, little bits of priorities on different papers. I think there's something about how do we bring it all together so there's a much more focused and aligned priorities and agenda for focus on particular items.
Definitely. Thank you, Patrick. Yes, Kate.
It builds on what Patrick's saying. And we've spoken about this before, but I'm very passionate about this, but also it's there is something about the critical mass of it to get the volume at the right level, because it's something that I think is very much seen as a nice to do, and actually it should be a core part of all of our workforce planning. And I think just it's in there, but not to undercook our voluntary sector colleagues and our kind of broader colleagues' input in being able to target certain pockets of communities and know where that need is in terms of that in reach, and understanding that actually the person who needs to have the conversation with that community is probably not us in terms of how do you want your career to go. So I think it's just making sure that we are releasing control at the same time as pulling kind of this together as a coordinated piece of work.
Thank you, Kate. Sally.
Thank you. Yeah, I think it's really helpful and great to hear all the good work. I think just building on Liz's point particularly, I think that's a really good place to take it, because I think there's some sort of early adopters been doing some great work, and then it's about how do we share that and get more people on board strategically as a, you know, it should be a strategic ask to the system to say, let's all be part of this together. And I think that's natural, isn't it, to have some early adopters and then let's go wider. So I think taking it to the public, I can't remember the title of it now. What's it called? Public Service Committee Board would be really, really helpful.
Sally. Nice.
I'm just wondering whether this links in with the employment and health GSNA, because we just talked about what employers should be doing in order to take the actions forward and the recommendations forward of the employment and health GSNA. And it looks like this is exactly what the employer should be doing to support that work. So I'm just wondering whether the two should be tied up a bit better. And thank you very much. Great report. Thank you.
Certainly. Thank you, Raj. Thank you very much. We will move to the report recommendations. We are being asked to A, agree that NHS and public sector partners pursue Anchor as an approach via the high-level board commitment that is the hallmark of effective anchors. B, consider how the partnership could be further strengthened with senior officers allocated to a strategic steering group to enable allocation of appropriate delivery resources. And C, help to identify which anchor pillars should be prioritized and any sources of support from existing resources. If everybody is in agreement, I'll take it. The board is happy to support these recommendations unanimously. And we move to item number 7. Thank you very much. Yeah, we are moving to item number 7 before the break, which is joint strategic needs assessment for the health of older people. The report provides an update to the JSNA action plan and will be introduced by Emily Smith, a consultant in public health at Peterborough City Council, and Val Thomas, the Deputy Director of Public Health at Cambridgeshire County Council.
Can everyone hear me? Okay.
Yes.
But welcome everybody. So the report I'm bringing today is a follow-up to the Older People's JSNA, which came to the board in March of this year. There was a discussion at the board at a time about the format of the JSNA. So the one we've just seen on the employment was the first example of the new style of JSNA, and this is the first example of the new implementation of the JSNAs. So at the time, there was a lot of discussion about how the board supports North and South Place to take ownership and to take a leadership role in embedding the recommendations. And the ask was for both North and South to consider the recommendations and to develop actions in response to them. So what I brought today is essentially a summary of the responses that North and South have developed. Both places have considered the recommendations, they've aligned them with their own areas of priority work, and they've kind of highlighted the areas that they wish to take forward as priorities. I don't think either place has yet got to the point of a fully formed action plan, and I think that's probably something for the board to consider in the second recommendations to what you would like to see moving forward as assurance around the implementation of the recommendations. But happy to take any questions.
Right, members, any questions for Emily or Val, or any comments on the report? Sally.
Thank you. I just wondered if we could pick up on that point from both places around how this sits with plans and being able to work up into more formalised actions, recognising that there's lots happening in place at the moment. So I just wondered if John and Erin could speak to that a bit, possibly.
Yeah. Shall I start? Hello, I'm John Rook, Managing Director of North Cambridgeshire and Peterborough Care Partnership. So this is our new way of operating. We wanted to get our experts in public health, set out the needs of the population, and then we as partnerships then build our response to it. And are extremely comprehensive JSNA. So thank you to colleagues in public health, and thank you for the advice around what the evidence tells us about the response to. How we've done this is then take it through our boards, and if I just give you how we've done this in the north of the patch, as an example, we took this to our partnership. We gave an assessment of where we thought we were against many elements of this, and then started to actually then map some of the gaps, particularly in some of that. So looking sort of at our triangle of need, I'll do a triangle for anyone who doesn't know what it looks like. Starting at the top, for people who are acutely unwell, what's our response? So particularly in the north of the patch, we know we want to strengthen some of our same-day emergency care systems. I think in the south of the patch at CUH, we've got a really good radar service, it's called, which supports older people not to be admitted at the point of crisis. We want to replicate some of that in the north of the patch. And then particularly when you come on to your next agenda item about the Better Care Fund, many of our pathways out of hospital are quite disintegrated and have historically been. So we're doing really positive work across the partnership around how we support people who need care and support at home in pathway 1. Now, what sort of community beds do we need in pathway 2, to say actually how do we build a more integrated, joined up approach to supporting people when they really are at their most vulnerable. Below that level, we have something called personalised care planning or proactive care planning that we're now doing across the patch, and that's particularly focused at older people this year from our learning from last year. So happening across our neighbourhoods, through our neighbourhoods, to identify those people, and they're coming from a range of different sources. Some of that is through data-driven insights, through general practice systems, some of it's from adult social care or community services, some of it from the voluntary sector, to then identify that. So far this year, we've done about 1,000 care plans for those people at risk in the north of the patch. We expect that to be about 6,000 in total, but that's the start of our capability, because the 10-year plan for the NHS says we should be doing 95% of care plans for people who are vulnerable by 2027. So that could arguably be tens of thousands of people that we need to grow that proactive service into. The other thing we recognise is that we don't do comprehensive geriatric assessment planning systematically across our population. We know at particular cohorts how effective that is to help people plan their life, to think about their social needs, their pharmaceutical needs, their life choices, and how they want to live the rest of their life. So to do that in a multidisciplinary way systematically, we've done some work across the north and south of the patch with partners. About 150 care professionals came together to say, how would we develop and design this? Something we colloquially call new models of care for people who are in later stage of life, to support them. So we've got the fabric of that model built by local professionals that now we want to embed in each and every one of our neighbourhoods. So think about how we identify through data, through local knowledge, and then make sure we do the evidence-based practice to support them from a health and social perspective of their lives. And that has tremendous benefits, and the evidence is so strong around doing that systematically in a population, and other countries do that really well. So that sort of level of identification of people in older age and that support through their local neighbourhood is a very much part of the National Neighbourhood Programme that we're embedding. So how are we building core teams that wrap around that? That's what we're doing today. Tomorrow, that's our task in the neighbourhood world, who are the group of professionals who are going to look after people when we prioritise them for that support. Then at a sort of population level, when we looked at this as a board, we said, actually, we've got some brilliant pockets of work where we support people to stay fit and well. So Emily's advice always to us is actually you need to have a generalized service as well as a focused one. You need to think about the total population. So some of the really good pockets of good practice are, we take about 1,000 people who the local GPs identified just down the road in Huntingdon, and we invited them all to go and participate in formalised sort of exercise programmes provided by Hunts District Council. The uptake was tremendous. The stickiness of people staying with those programmes at their own cost was tremendous. And we know that the outcomes are a lot better for people if they exercise regularly. So building on pockets like that, how do we make that more systematic through our offer? How do we then make sure we target people so they recognise there are all these assets in their community that they could then use? So in summary, we've got a good start. We've got to get a lot more systematic and build this capability through each and every neighbourhood in our patch.
And hello, everyone. I'm Erin Lilly. I am Director in the South Place Partnership. I won't repeat everything that John said, but most of that applies to the South as well, as John's touched on. The couple of extra bits I thought it might be useful to just add a bit of extra kind of detail or colour around are so we're seeing some really good work coming through from Adam Brooks and particularly the geriatric team there in terms of how we work with care homes and link with the community matrons for frailty and the primary care network and build a bit of a team. And it's only been a few months, but we're seeing some really good shift in terms of use of urgent care response jet team and also admissions into the hospital from those care homes. So small pilot, but we're now talking about how do we extend that beyond that kind of 1 year of funding and think about how we make that more systematic. John mentioned the high impact use program and the kind of proactive care planning. Now starting to open some conversations around how we identify those people through the discharge planning process and not wait till we can find them in the GP data, perhaps a month later when someone's done the search. Really valuing the input from the voluntary care sector in terms of some of that discharge support and thinking about their role in that space. I think the other bit was just we do have the startings of that action plan, so I think that's a really good recommendation from Emily for us to take forward. We've mapped out our locality plans, so our clusters of neighbourhoods at district footprint against ageing well as a kind of as a cohort. So so a lot of the small pieces of work, as John talked about, are there. What we need to do now is to just keep doing that kind of cross-pollination and translation into other spaces and other neighbourhoods and make sure we've got that prevention, then the proactive bit, and then the targeted bit happening across all the neighbourhoods for this population group.
Very, very interesting. I think I open to the any more questions or comments from the board. Yes, Stephen.
Just really to comment that it links well with Peterborough have been successful in achieving Pride in Place funding for some particularly deprived areas of Peterborough, which is all about kind of regenerating areas, regenerating, I guess, sites and particular kind of land for community purposes, which we'll be looking at developing over probably the next 2 to 3 years. So it gives real kind of opportunities, and the programme is very much about working with local people, local communities to co-produce and develop services together in partnership. So we're looking to start that work really quickly, and I think it works really well with the kind of neighbourhood pilot as well, because it gives a real opportunity to look at the kind of wider determinants of health, you know, and really look at how we can develop services in partnership and develop a really good co-produced model, I think, in terms of how we work with communities to develop services, and reclaim maybe a lot of sites, a lot of services that aren't working to kind of full effect. So there's some really good, I think, kind of cross-agency opportunities to really use that money and to develop in partnership.
Thank you, Stephen. Yeah, Jan. Mike, sorry.
Thank you. Thank you very much. Just a number of observations, if I may. Firstly is quite a lot of older people are actually fitting well and contribute to so that's the first thing I would say, and they contribute, I think, quite a lot to voluntary services and do that with alacrity and a lot of effort and energy. So I think that's important to recognise. And of that group, the one that I'm most concerned about are unpaid carers, which I think must form part of this work. Shortfalls in the public sector provision the burden falls on the shoulders of unpaid carers who themselves may often be unwell. So I think both those things are very important. And then this is slightly awkward. This is me really, but I wonder what the driver is here. Is this to improve outcomes and quality of life for older people, or is this to relieve pressure on secondary care beds? And both are important objectives, but the language often seems to be, we're going to put in community care because we need to relieve the pressure on the acute sector because they're struggling to cope. And I understand that. However, I would have thought our primary purpose is to improve outcomes and independence and the ability to live a quality of life in people's own homes, which should therefore support our acute colleagues in terms of managing their bed-based delayed discharges and all of that sort of stuff. But it's just a question that I sort of ruminate on when I get home at night, you know, and I just wondered what your thoughts were.
Thank you, Maya. It sounds to me from the presentation that they are focusing on the quality of life, and that is great to hear. At least that's the perception. Jan.
So it's following on from Mike a bit, really, because a piece of analysis that we've done across the new ICB cluster shows that we have about 44,000 people with frailty and dementia. And of that, they're costing about 26 times the average per capita rate to care for. Okay, that isn't a judgment, it's a set of facts. The bit that I keep coming back to is that is only 44,000 of 3.5 million we've got in the population of that patch. And we have seen, haven't we, from evidence internationally, that what really helps with those older people is their status in the community, what is their sense of purpose, how are they still contributing. You know, it is greater than the healthcare services that we can provide. And I think it's just a bit of a note to ourselves for future discussions, really. If we're going to talk about older peoples, we do need to keep the wider determinants in mind and exactly what are the other things that we are doing to make sure that people at the age of 70 are employable in the anchor institution work. And it comes back to that overlap because, again, coming back to purpose, how are we working with volunteering? How are we doing those other things that will really drive a demonstrable difference for people in their outcomes longer term? And we know active mind sees off dementia, we know obesity sees off dementia, so all of this is interconnected. So I do think it would be really helpful. I would welcome a feedback on not just what are we doing for health services, but what is happening in that wider determinants, what are the other pieces, how are they all adding together when we're reviewing the JSNA, because it's not taken away from the brilliant work the whole partnership is doing on this, but I still think we're going to miss a point and keep doing the same thing if we think we're going to service our way out of what is an increasingly high level of utilization. And I'm thinking particularly of how we're going to address things like helping people avoid or delay the onset of dementia as long as possible. Well, that is about active mind work as much as disease prevalence. So I welcome the feedback. I think it's great. And I think the joint working on this has been brilliant. I just think we need to keep our mind on what is really going to make the difference and what is each partner doing to help that to get the whole population's improvement seen.
Thank you very much, and we're going to get along well. It's checking your numbers. Yeah, 45,000. You mentioned, John, you mentioned 1,000, trying to escalate to probably the 10,000. We are looking short here.
Yeah, I mean, I think the on the numbers, Jan's absolutely right. You know, if you calculate sort of the cost ratio with some of the population, the higher up that triangle you go, then you get the more intense utilization. It's, I suppose, the point at which you provide your interventions to have to be most effective with scarce resources, and that's why Emily's point about what are we doing generally for the population who are getting older at a universal level is really important. As Jan has articulated, actually that is more than just exercise, as the example I gave. That is about employability, that's about social infrastructure and so on. I think if you categorize some of the people by some of their different need, and we can do that now because each one of us in our system, in our GP systems, has an electronic frailty index, whether we like it or not, that's automatically generated for us. We can use that information. It's a good indicator of need for some people. It's not for others. But you can use it as a guide for actually what might people need at different stages of their life and offer that support. It's not dictating what people have. But I think through use of that data, use of combining data from different agencies, enables us to give people the best chance of accepting some of the offers of support that we are giving. And I think that's the important factor. We know we have the ability to influence people positively or divert them from crisis. And there's very strong evidence around that. And particularly when I go up the higher end of that spectrum towards the sort of 44,000, what you invest in that from an economic point of view, there's a 3-to-1 payoff in terms of what it saves and that's, take it to a human level, you're avoiding someone having a crisis, you're avoiding someone fracturing their neck or femur, you're extending their life expectancy, because once you fracture your neck or femur, your life expectancy is dramatically short. So those falls, those particular life-changing events that occur, we have data which helps us target the intervention, not absolutely precisely, but more and more precisely.
Thank you, John. Very briefly, please, Neil.
Yeah, I mean, it's 44,000 over 3.8 million. So Cambridge and Peterborough is 1 million of those 3.8 million. So the figures are slightly different, but the point's, valid. I think if you look at, to Mike's point about, are we looking at outcomes, and positive stuff, or are we looking at kind of money and hospitalized utilization? I think the truth is you've got to look at both, because I think in the future, when we accept that there's a scarcity of resources, if we identify the 12 or 13,000 that will be the equivalent for Cambridge and Peterborough, and we look at how services are providing care for them, I guess one could question, why does someone in that frailty group need to see a cardiologist, a rheumatologist, a orthopedic surgeon? We are utilizing our capacity in ways that don't really make a difference at the moment. And I guess going forward, what we'd want to be doing is being a lot more strategic about how we use our capacity. So actually, how are we using the hospital end of the capacity? How are we using the community end of the capacity? And to Jan's point, because the wider determinants of health plays such a big part, how do we free up resource to actually invest in those wider determinants of health? Rather than ignoring them, we should be doing things to actually help the population be healthier, be fitter, be more mindful, have jobs, etc. And that's the way I think, that we see ourselves as things like the North Place Partnership trying to make a difference here.
Thank you very much. Neil, Patrick, yes, one more comment there.
Well, it's just to follow on from a couple of points, really. So the first one is that whilst there are a lot of older people who are fit and healthy, there are a lot of younger, aging people who are very unhealthy. And I think we've got to think around the preventative work that we do here. Some of that's around that earlier conversation around people going into employment. It's about supporting people to deal with their mental health and help them to get into employment. So I think we've got to think about, yes, there's a significant pressure already with the older population we've got, but there's a potential tsunami with the population aging. The other point to note is that I think it was the JSNA we talked about a focus on carers and about carers being economically inactive and about how do we support those to be both active carers but also supporting them around their own well-being and back into employment. And then interestingly, around the 16 to 24 age group being the most economically inactive. Well, with an aging population, you need the younger population to be economically active. So there's an interest in connecting all of these papers that we've seen this morning to make sure that there is a focused and joined up way in which we bring those together, so our priorities and our resources are directed at the right things, not dealt with as separate papers that we see here that miss the overall point.
Thank you, Patrick. Yes, Melanie.
Thank you. Obviously, I'd like to say something. I totally agree with everything that's been said, really. I think there's two perspectives to this. You've got the reactive prospect of how you need to support people, but then you've got the prevention. And I think some of this really comes down to the public's attitude on ageing. The younger we are, you know, I need to be really thinking about my older age, but actually I still think about lots of other things about when I was young, and I don't feel very old, but actually I know because of the job I do that I need to be active and I need to do all of this. And I just wondered if you knew about the Age UK National Charities campaign called Act Now, Age Better. And I think it could be really, really useful for what you're doing. And then I guess it's a question. When we talk about prevention, it would be really good to have a more local perspective of reflecting on younger age and how the impact can really affect you in older age. So even if we put some ages in, you know, set it at 50, we all feel really young at 50, but actually now's the time to act. So I just think there needs to be more reflection on the preventative side. Thank you.
Melanie. Yes.
Sorry, I just wanted to pick up on.
Sorry to interrupt. Please remind me of your name because I didn't catch it the first
Yeah,
time.
sorry, I'm Erin.
Erin, thank you.
Just pick up on Patrick's point before, actually, about all the JSNAs, because that's what I've been scribbling through my book as well this morning. And I think that's where the neighbourhood health plans start to come, just to go back to the starting conversation. That's, I think, our opportunity to go, well, the JSNA for this one says this and this one says this, and actually how we're going to pick that up for this neighbourhood or this bunch of neighbourhoods, I think is where we can start to join some of those dots. And that will take a bit of practice, I'm sure, to kind of work through that, and we won't be able to do everything all at once, but I think that's our chance to say, well, actually, here's where we join some of those up.
Thank you very much, Emily, Val, John, and Erin. And
yeah,
Val,
two
one more,
things.
yeah.
One is it makes me think of healthy aging. We seem to have forgotten that, and I think that's very pertinent to a discussion we've had around prevention. But the other point was, and I think Erin said very much I was going to say, because I was thinking back to the JSNA that we talked about just now, and we talked about the recommendations, but we didn't, I think Kate approached an action, but we didn't sort of say yes in the same way as this has come back. And I think it's been a useful discussion, and we should do it with all JSNAs. And part of that coming back is reporting and how we've developed the collaborative working and how we've grown it. Otherwise, JSNAs will come here and they'll go away. So I think it's really good to bring this back and to hear what people are doing with it. And I would suggest we come back with all JSNAs, and the one I just did it after a time period, and show not just the progress that's been made in specific deliverables, but how that interconnectivity across the system has been developed and grown.
Thank you, Val. We will move to the report recommendations that we are being asked to. A, consider responses to the health of older people joint strategic needs assessment for the North Place Partnership and South Place Partnership. And B, agree that the North Place Partnership and South Place Partnership should provide updates at the next Health and Wellbeing Board and how they have embedded actions in a structured way into their work plans. If everybody's in agreement, I will take it. The board is happy to support these recommendations unanimously. And we will take now a short break. Shall we say 5 minutes? 5 minutes, and then we reconvene with item 8. Thank you. Hello, everyone. I'm reconvening the meeting now. Thank you very much. We are now moving to item number 8, which is a Better Care Fund update. This will be presented by Caroline Townsend, Head of Partnership and Programs at Cambridgeshire County Council, and Sandra Pitley, Associate Delivery Partner for Performance and Delivery at Cambridgeshire and Peterborough Integrated Care Board. Welcome. Thank you.
Thank you. So the report today actually covers a number of areas and updates in relation to the Better Care Fund, and there are a number of appendices associated. We have the formal approval that we're requesting for both the end of year NHS England submission for 24-25 and also the Q1 25-26 submission for NHS England. And also you will see the final version of this year's Better Care Fund plan and narrative and template is also part of this report, so that you have that for transparency. I think very much, obviously, you'll see from the reports where we are in terms of our current performance and how we're monitoring that and what that looks like for Q1. But I think particularly wanted to draw to your attention some of the aspects that we are seeing coming up around information on the Better Care Fund for next financial year and what that could mean in terms of planning opportunities and how we move forward with that and ensure we've got the alignment across the system. Particularly one of the areas that we are hearing out of the early feedback in relation to some of the national review. So there's currently a national review of the Better Care Fund being undertaken. We are hoping to get some more confirmed information on that autumn at the earliest. Some of the early information we've received is that they are looking at more definition in terms of a split between the BCF being much more focused around hospital flow, and then in terms of community and neighbourhood health, a bigger focus in terms of local neighbourhood health plans and how they support delivery. So it's actually quite a good timing for this report, just following on from the previous one. Definitely a real focus around how we shift from that acute community as part of that neighbourhood health and what opportunities that will lead in terms of being more upstream around prevention and intervention. I think it's also probably important to note that as well as the opportunities around some of the shifts that we're seeing around system organisation and changes also present challenges as well, because we've got a number of moving parts, but definitely looking at how some of those local footprints and the local health partnership can actually support some of the delivery as we move forward and we get more clarity on what that looks like. I'm going to pause there to take questions.
Thank you very much. Questions from the board? Okay.
Hello. I think you've made the point already, so I'm just reiterating it really, but I think it's the timeliness. I think we're at a point where we are putting together neighbourhood plans, understanding how the governance needs to work differently to push for accountability and visibility. And I think this is a area that actually we need to make sure we are absolutely maximising the possibility of. It's one of the kind of few very central parts, and I think we've been on a bit of a journey to get to the place we are now. So there is something about consolidating that, and I think just linked to what Val said with the last agenda item, how the outputs and the decision making play through. So is visibility in forums like this is really important. So not really an action or a question, but more of a kind of acknowledgement.
Yes, very important. Yeah, it seems to me from a very new set of eyes that we are overlapping there, but Neil.
I mean, the Better Care Fund has always been huge sums of money that's shared between sort of statutory services. And I think when the neighborhood agenda first came out, it kind of felt a bit like things were being badged towards neighborhoods. So we were looking at our spend and going, well, this stuff fits with the neighborhood agenda. And I think kind of going forward, though, with the kind of importance of neighborhoods and neighborhood working, it will be good to have those fresh pair of eyes to really think through, well, actually, these huge sums of money, what are they going for on, and how is it helping us as a health and wellbeing board system to progress in the way that we've been talking about with the previous items.
Thank you, Neil. Any further questions? Sandra or Caroline, do we have any further comments to your?
No, just that I very much agree with both of those comments, and I think this does present an opportunity to actually look at things through a fresh set of eyes. I think one of the other things that we're very much seeing more recently from the Better Care Fund in the NHS England is a much stronger focus on performance as well. So wanting much kind of clearer ties between actually where are we spending money to what is that delivering, and actually being able to kind of look at those outcomes through the lens of what we want to deliver at a local place-based level necessarily, rather than looking at it as specific funding streams, but how we bring the funding together to deliver those outcomes, and looking through a new lens, really, and a refreshed lens will be really valuable.
Thank you very much. We will move to the report recommendations. We are being asked to formally approve the 2024-25 end-of-year NHS England submission, formally approve the 2025-26 Q1 NHS England submission, note final Better Care Fund 2025-26 narrative and planning templates, note and comment on progress to date and future years planning. I will take it the board is happy to support these recommendations unanimously, unless anyone indicates otherwise. Thank you. We'll move to item number 9. Thank you very much, Caroline and Sandra. Item 9 is the Health and Wellbeing Board and Integrated Care Partnership Annual Report for 2024-25. This item will be introduced by Kate Parker, the Head of Business Programs at Cambridgeshire County Council, Sally Cartwright, the Director of Public Health for Cambridgeshire, and Raj Lakshman, the Director of Public Health for Peterborough. Kate.
Thank you. I'll just quickly introduce and then hand over to Kate. So this is clearly annual report that we look at every year, but it's a requirement. But we had lots of conversations behind the scenes on making sure that this is meaningful, and going forward that we'll, for next year, really be thinking about how we tell the story of all that we've achieved, and particularly in light of all of the changes that are happening, but really making sure that we're still driving actions through this group. So I think the paper Kate will talk to, but is a really good summary of where we are now to then lead us into thinking about that for next year as well. So over to Kate.
Thank you, Sally. So yes, you've got the annual report for 24-25, which talks about the activity that we've done over that year as a Health and Wellbeing Board and Integrated Care Partnership. We've also included at the beginning of the report a bit of a timeline around the journey that we've taken. And I just want to extend, I know Councillor Navarro said it earlier, but I want to extend my thanks to John O'Brien, because he was there right from the start when we actually established the committee in common process. So he has written the forward, so I think just want to acknowledge that. So we've actually reported on the kind of activity that we've taken over since 2022 as well. The annual report highlights the progress against the 4 priority areas of the Health and Wellbeing Integrated Care Strategy. And as a board, you received updates from each of those priority 4 leads at your last meeting in June. There's a couple of highlights in the board report that I just want to pick up for each of you in regards to the priorities. So just for priority 1, I just wanted to pick up on the fact that we've seen some immunisations increase in school-aged children. For priority 2, we've done some work around behaviour change insights works that we've commissioned. Priority 3, housing and health. There's a separate subgroup now for the housing board that specifically focuses around housing and health, and is taking a lead on the JSNA that we're working up. Priority 3, obviously it feels like this happened a long time ago, but just bear in mind this report is 24-25. So just picking up on the work well and the successful bid that we did as a partnership approach. And then priority 4, we saw as an outcome the mental health JSNA that the board received, I think, in your January meeting. So these were the kind of key activities around 24-25. One of the things that Sally also mentioned there is we want to try and make this a bit more meaningful going forward. So we are actually looking at different ways of producing an annual report and possibly looking at web-based links as well, just to make it actually more accessible for the public as well. So this is something that we'll look for the 25-26 year ahead. We're also, the cover paper also talks to you a little bit about plans for January 2026. So we are actually going to review the latest data of population health needs and inequalities, and that's scheduled for that meeting. So it's proposed that there's a full review of the Health and Wellbeing Board outcomes and measures and the associated output metrics to ensure that we're actually measuring what matters, because we appreciate that when we actually set the priority areas and the metrics, this was back in 22 and things have moved on. So we want to kind of make sure that they're actually fully aligned to new developments and outcomes, including the local government outcomes framework. So that will be coming to your January board meeting. And this alignment is going to support the integrated reporting and enable clearer benchmarking against the national standards that you'll receive as a board. So part of that approach will be looking at the processes then and discussing at the January meeting how you want to receive updates on the Health and Wellbeing Board strategies. So obviously we provided you with a whole annual update at the last meeting, but perhaps you would want to see kind of progress at each of your board meetings, so that you've got you're aligned to kind of you've got sight of developments and things that we need to actually perhaps address. At the end of the joint annual report, there's some recommendations for the board in terms of future focus, which again were presented at your last meeting. So it's really your opportunity to say if there's any comments that you'd like me to kind of, any changes that you need to the annual report before it goes to both four councils to be adopted at the end of this year. So, thank you.
Thank you, Kate. Sally or Raj, anything to add to that? Or
thank you.
no? Any comments or questions? Liz, we start with you. Sorry, Kate. Liz was first.
Oh, actually. Thank you. I'm a bit torn, I suppose, Kate, because on page 8 of the report, page 270 of the pack, the data that we're presenting is so high level that it's really hard to kind of really tell, you know, how well or poorly we've done. And, you know, I think there was something about this board doing more than just looking at a set of performance data. But equally, I think if the board is going to demonstrate progress, I think we need more than is presented here in that little table with the kind of the equal sign and the cross and the green star. So I don't want to make this really kind of performance data heavy. I think we need a bit more than that.
Can I respond?
Kate, yeah.
Can I respond?
You can indeed.
Yeah, so Sally's probably going to say exactly the same thing, so I'll pass back to Sally in a second. But that's exactly what we're hoping to achieve at the January meeting when we look at actually what are we going to be reporting on going forward.
Yes, just building on that, completely agree, Liz. So we were looking at the outcome measures that have been agreed previously in this board, and just trying to make sure that we're keeping the line of sight to them and we haven't lost what we're hoping to achieve through the ambitions that have been set. but made the decision not to include all of that in this because it's quite a bigger piece of work that needs to happen to make sure those are right and that we can collect the right data, and if there's anything more that we should be saying underneath that to show progress. So that will all be coming to the January meeting rather than try and do it too quickly and pack it into this report. But ideally it would be in there as well. So I think going forward, once we've done the proper review and you can have a wider conversation about what it's looking like in terms of the data in January, we can build it into the next year's report.
Thank you, Sally. Kate.
Mine was a sort of related point because I think been part of those conversations, and I know we have had a dashboard that we haven't necessarily routinely used, and there is something about this as a meeting, as a gathering of leaders of the system, being really clear on what comes in front of this group and how we track progress. That's been the nub of the challenge to ourselves, and I think that would change the tone of the meeting, and in terms of focus on activity and the impact of that activity, which is something we've all kind of committed to wanting to get into a better space on. I think there just has to be acknowledgement that, as Sally said, it takes a little bit of time to get there, but we've got the data, and I think it's about giving support. And then the other point was just Kate's done a huge amount of work to pull this together, and it's not always the most fun thing to do. So just hats off to her for her resilience and making sure that everybody's contributed to it.
Thank you, Kate. I have utter confidence in Sally's team. Yeah. We will move to the recommendations. Raj, yeah, you can.
Just one more point. I think a lot of the detail behind it came to the last board meeting in terms of looking at the dashboard and where we are at with the dashboard. So just to support Kate, a lot of that detail was in the detailed report that came to the last board. I think it's clear that these are high-level outcome measures and they'll take a long time to shift. And what you're asking for, Liz, is more proxy measures in terms of what may shift. And we have that in the local government outcomes framework, just like the NHS has more proxy measures. We have that in the local government outcomes framework as well, which has been through consultation and will be finalized shortly. And there are things that should change. And then probably what we are talking about is then the action plans that will influence those outputs, which will then affect the outcomes. So I totally agree, these are high-level outcomes, but then we need to look at the outputs and the action plans that then go in that way. So what we have here is a mix of outcomes and then deliverables and actions that have been taken.
Thank you very much, Raj. Right. We will move to the report recommendations. We are being asked to review and comment on the annual report for 2024-25 before its submission to both local authority full council meetings in November and December 2025, and agree the approach to refreshing the health and well-being board strategy performance strategy performance reporting. I will take the board is happy to support these recommendations unanimously, and we move to item number 10. Thank you, Kate. Item 10 is the Cambridgeshire and Peterborough Pharmaceutical Needs Assessment Final Report for ratification. Following its approval under delegated authority, the report is introduced by Ian Green, the Service Manager of Wider Determinants Health in all policies at Peterborough County Council, City Council.
Yes, thank you, Chair. So I'll take the paper as read, but before I go through some of the key points, I just want to give huge thanks to the people that contributed to the P&A itself, so particularly to the ICB pharmacy lead, so Sati Yubi in particular, the local pharmaceutical committee, the LMC, Health Watch, and then the actual commissioners of public health and pharmaceutical services, who have all contributed to the JES, to the P&A over the last 12 months. So as you've said, Chair, the decision to approve the P&A was made at the Chair's meeting last month. Just to reiterate why that decision went to delegation is because the timings of the board never quite coincide with the timings of the P&A. Legally, we had to have the P&A signed, approved and published before the 1st of October. Today's the 3rd, so those dates never quite coincide. So the report was taken to the chairs, the P&A was approved, so today is just for the board to ratify that decision, but also to pull out some of the key findings of the public consultation that was then made public when the P&A was published at the end of last week. So the public consultation, there's a snapshot given in the covering paper, but it's important to say that we only publish the statutory questions, if you like. So we tend to ask questions about, is the P&A fit for purpose? Does it really cover what we think it needs to cover across Cambridge and Peterborough? Do you agree with the findings? That's fine, but actually we ask a lot more questions. So we ask questions about satisfaction with pharmaceutical services. We ask questions on the services that people think should be available through pharmacy and dispensing practices. So my intention as chair of the P&A steering group is to produce a separate report that can go back to commissioners on that wider views of the public. So it's not part of the P&A consultation itself that gets published on the website, but I think there's a rich source of information there that we need to share wider to board members and commissioners in particular. So my intention is to do that as we go forward over the next 12 months. And I think the other bit to pull out is there's some lessons for our communications teams and actually how we consult the public. So we had over 200 responses to the P&A, which actually is quite good. Looking at other P&As across the country, we've not done badly. So if I look at the Isle of Wight, they had 5 public responses to their P&A. I think when the other ones only had 50. So we've done very well as a local system. But there are lessons to learn on the type of questions we ask and how we ask the questions, and that came back through the feedback. So once again, I'll produce a separate report for our comms leads across all organisations that we can look at actually how do we consult the public on NHS services and pharmaceutical services going forwards. And then the last point to make is very unhelpfully during the public consultation period, the government changed the guidance for P&As and required a new way of doing P&As that we couldn't actually address during the public consultation because we'd already written the P&A, it was already in draft form, it was out for consultation. So the main change in that guidance was to look more systematically at the needs of particularly rural pharmacy and what would be the implications if a pharmacy were to close over the period of the next P&A. So if a rural pharmacy, where that's the only way you can get your prescriptions, were to close, what were the implications for service delivery going forwards? Now, the guidance also says that if you're going to do that assessment, you need to publish a new P&A and therefore go to consultation again. So our intention is not to do that in a formal way, but for commissioners to look very carefully at the implications so that if a pharmacy does apply to close, we know what the impact is going to be prior to that date. So our intention is to do that work behind the scenes so we have a ready source of information on what the impact would be on rural pharmacy services if we were to lose one or more pharmacies locally across Cambridge and Peterborough, rather than doing the whole P&A again, because we're then subject to the statutory consultation period and in the middle of ICP changes and LGR, that's probably not the right time to do that. So my recommendation to the steering group is we do that piece of work behind the scenes, we have that available in case we need it. But happy to take questions on the P&A or the public consultation.
Thank you very much, Ian. And yes, it'll be interesting if we don't do it already to probably take part on the process of new public consultation and the questions that you're asked. I'm sure that around this table might be some experience and probably some feedback. Questions, comments? Jan.
Can I just check the questionnaire? So just having clicking the link. So there was 198 people from the public that responded, according to this, and then a couple of people from pharmacies, 3 people from Health Watch, and 2 people from NHS Improvement. the questions in it. So the first question is, do you feel the purpose of the pharmaceutical needs assessment has been explained sufficiently in the draft report? As I read the questions, it's not really saying what do people want their local community pharmacy to do for them. What we're doing here is, has the process that we run done it, which is absolutely fine because that's what we're asked to do. But I do just think as we're listening to it here, we should just take note that we're not actually saying, if you think about small communities, so if I think about the work we had to do in Sutton last year, the golden triangle for that small village was their GP surgery, the post office and the pharmacy. It's the absolute golden triangle for what made that community thrive. So I do think we just need to, this is a process, and I completely accept that it's been done well and we are where we are. But I think, is this solving the problem of what should community pharmacies be doing? Are we really pushing the boundaries? Why are we still having blood tests done in GP surgeries and not in pharmacies? Things like this, we're going to have to push the boundaries of this. So I completely accept this report. I think this is a process issue that we've done. I think the challenge for us as a health and wellbeing board, which we might come on to in the strategy session, is yes, and so what? And how is this, is the need for a pharmacy a business need or a distribution need, or is it a community need? And I think there's a balance here we've got to strike. So I absolutely think this is a really good piece of work for what we were asked to do. I just think we need to challenge ourselves on what is the role of these things in our communities.
Thank you, Jen. Well, that feedback came back earlier than I thought. Any more comments or questions? Kate?
We've lost John and Erin, I think, from place. We've got Zoe and Neil here. There is something about how we work with our place teams and boards to build on what Jan is talking about as well, because there is a community asset element to it. This as a piece of work, and our neighbourhood plans have been asked really clearly to do that join up work with actually what are the assets that, to use Jan's analogy of a golden triangle, that sit within our neighbourhoods. So there's something about turning, and Ian does all the heavy lifting for this, don't you? It's how do you turn that into actually kind of from an operational perspective, what does that mean? And how that feeds into some of the decisions we end up making, often in a reactive sense, for when we have elements of the service provision that goes offline or are not functioning. I think there is something about how we are having a coordinated approach to championing our pharmacies within our community settings as well.
Kate? Neil?
Yeah, I think it's a really good point. I mean, when people are talking about the left shift of the NHS, then often, as GPs, we're thinking about things moving from hospital to GP, or CPFT might be thinking people, moving from hospital to community. But there's also that thought about what can move from GP or community into pharmacies. I think it's a really good question that Jan poses. And, actually, none of these things happen without planning, without thought. And obviously, in Cambridge and Peterborough, there was a Pathfinder system that was put in place by the ICP that was looking to explore what is possible. So what could be the future of community pharmacy as well. And so, I think we have been trying to do some stuff, but I think there is more things that we could do. And certainly, I think we'll take this back to North and South, I'm sure, to think about what involvement we have. I think the development session is, for example, talking about obesity and things like that. And, again, community pharmacies do have a big part to play in kind of obesity drugs, but could there be more than that, in terms of lifestyle interventions?
Thank you, Neil. Right. We will move to the report recommendation.
Before you do, Chair, can I come back on a couple of those points, if that's okay?
Absolutely, please. Thank you.
So there's an offer, and I think it's probably worth me looking at the consultation results, coming back to North and South boards with the views of that consultation, because we ask questions like, what services do you want your pharmacy to provide locally? What barriers do you have in terms of accessing pharmaceutical services, whether it be transport or access? So we have much more data. I think we're always slightly hampered by what the guidance says and what we're supposed to be asking, because the guidance specifically says only ask about the process bits, if you like. I think the other bit is the guidance says you should only consult your statutory consultees, which tends to be the LPC, the LMC, Healthwatch, and the ICB. We always do a public consultation. We don't have to do that, but why would you do a pharmacy needs assessment without involving the public? It just seems a bit counterintuitive. So we always do that public bit. So I think if you're happy for me to come back to North and South and actually bit more of a deep dive in what the public have said about pharmaceutical services, because I think the other bit we don't quite appreciate, being a rural locality, is the difference between pharmacy services available through a dispensing GP and pharmacy services available through a community pharmacy, because they are slightly different, and the public pick up on that difference, and that's come out through the consultation. Thank you, Chair.
Thank you, and thank you very much. Now we move to the report recommendations. We are being asked to note the final pharmaceutical needs assessment as approved under delegated authority by the chairs and executive directors of public health on the 9th of September 2025, and note the indicative findings of the public consultation. No vote is required, so we move to item number 11 on the agenda. Item 11 is the agenda plan. Would the Democratic Services Officer let us know if there are any changes to the published report?
No changes, Chair.
Okay. Do any members have any comments or questions on the agenda plan? We will note the agenda plan. Before we close, I would like to remind the board and ICP members on an in-person development session on the 12th of November at the Lady Oliver Center in Brampton. This will be focusing on the Combined Authority Growth Strategy and the Get Britain Working submissions for Cambridgeshire and Peterborough, and will be led by Rob Bridge, the Chief Executive at the Cambridgeshire and Peterborough Combined Authority, and Andrea Wood, the Assistant Director of Skills and Employment at the Combined Authority. Our next public meeting will be on the 23rd of January 2026 in Peterborough. And thank you all for attending today. I declare this meeting closed. We'll be back 1:30, right, for them? 1:30, so enjoy your lunch. Thank you, Sally, for reminding me.